I think we're ready, Dr. Bedigo.
Great, thank you. So I'm going to call the meeting to order. It is 6:34 p.m. and we'll start with the roll call of the members. And if you could answer verbally, just because I'm having trouble seeing everybody on the screen at the same time. Dr. Usama Bilal.
Here.
Dr. Tyra Bryant-Stevens.
Here.
Dr. Ana Diaz-Rue.
Here.
Dr. Marla Gold.
Here.
Dr. Jennifer Ibrahim.
Here.
Dr. Hamid Ismail.
Here.
And Dr. Scott McNeil.
Here.
Great. Thank you all, and good to see you all. So before we get started with tonight's agenda, since we are in the middle of a pretty eventful week, I just wanted to give you a little bit of an update on what's been happening with air quality in the city. So last night, we peaked at an air quality index, and this is the smoke from the Canadian wildfires, which I'm assuming you all are aware of, but happy to answer any questions about that. But we peaked at an air quality index of 500, which is the top of the scale. And we certainly don't have records of any event like that. There probably were events like that before the Clean Air Act and such, but certainly in the last 50 years, we don't have a record of an event like that. So the health department has been working together with other city departments and agencies and with community partners to get information out to people, and some other kinds of measures that we can do to help people to manage this. But a lot of it has been about information, about getting people to stay inside as much as possible, to wear a high quality mask when they're outside. There's a little bit of ability to distribute masks, not a huge amount. Fortunately, right now, although we're still in a code red, we actually reached a code maroon, which we've never done before, but we're still in a code red right now. But the AQI, or Air Quality Index, is now down to 170. And that, by the way, is available at airnow.gov. You can see updates about once an hour. So if you want to see where things are, that's the best place to get information and close to real time. If the forecasts hold, we're hoping to be down out of the red zone by tomorrow, but it's been pretty unpredictable. The fires are continuing to burn in Canada. So, the situation is improving. We're watching it really closely in collaboration with other folks across the city. The good news is we have not seen a real uptick in either ER or hospitalizations, and even in our own city health centers, really haven't seen an uptick in respiratory illness. And as far as I can tell, that speaks to the fact that Philadelphians have actually paid attention. They have stayed inside. They have masked when they're outside. It was really striking. I was out in North Philly for something else last night, and the streets were empty. And, taking a route that I've taken a bunch of times before, and there's usually a lot of people out, but the streets were empty. So I think people really are listening to this. And I think it's helped by the fact that it's kind of hard not to notice when the air is that thick. But any questions about that before we go on to the actual topic of our meeting?
I actually have one, Cheryl. I'm wondering on the, I know today you made the decision, or last night, whenever made the decision to not have sanitation workers out, city non-essential, and then non-essential city out. And I'm wondering, is that a decision that you make like case by case, like something that you said, okay, this is really high, we need to avoid people having to work outdoors, and if whether that's something that could be like protocolized, like saying from now on, every time AQI crosses 200, so to speak, we do that.
So it's something we're talking about. I will say that we haven't had the AQI cross 200 for many years. We looked back, I think it was 2007, 2008. We had a couple. So we have had an occasional code red day, but those are isolated single days, just barely over that threshold. It's a very different situation than going into a code red where you kind of know you're headed on up from there, and it could be days. So I think it's a good question because of climate change and because of the likelihood of additional fires, but it hasn't come up before. So it's just something we're starting to explore as we kind of grapple with what's happening now. But, I was glad to see the city decide to keep people safe today. So. Okay. So I'm now going to turn things over to Ben to explain the public comment process.
Thanks, Dr. Medicolegal. Good evening, everyone. My name is Ben Hartung, and I'll be facilitating the comment process tonight. If you'd like to submit a written comment on any of the regulations that'll be presented tonight, you can do so by using the chat feature on the Zoom meeting, or you could send me an email at Benjamin, BEJAMIN.Hartung, HARTUNG, @phila.gov, PHILA.gov. The board is required to review any comments that are submitted tonight before voting on any regulation, but they're not required to respond to your comment or question directly during this meeting. And if you are participating in this meeting, I just want you to know that it's being recorded, and the recording will be posted online per city ordinance. So your participation in the meeting constitutes your consent to have your comments recorded and published. Thanks. Hope you're muted, Dr. Medicolegal.
Years into this and still doing that. Next, just check if the board has had a chance to review the minutes from our last meeting. Is there a move to approve the minutes?
This is Jen. I'll move to approve.
Is there a second?
I approve.
All in favor?
Aye.
Aye.
Any opposed? Great. Thank you all. So tonight's agenda, we have two items on the agenda. Firstly, a regulation requiring a permit for cremation, burial at sea, body donation, or other non-burial disposition methods related to deceased persons. And that'll include a presentation by Philadelphia's Chief Medical Examiner, Dr. Constance D'Angelo. And then second, we'll review an amendment to the regulations governing the control of communicable and non-communicable diseases and conditions regarding monkeypox, otherwise known as Mpox, and pediatric multisystem inflammatory syndrome. And Ben will present on that. So I'm going to turn things over at this point to Dr. D'Angelo.
Hi, good evening. Connie D'Angelo, Chief Medical Examiner. Just wanted to give you a little bit of background before Ben goes into the proposed regulation, and then I'll finish with some of the expected outcomes from approval of the regulations.
And I'll share my screen now, Dr. D'Angelo, for the presentation.
Thank you. So just as a reminder to everyone that the Medical Examiner's Office is part of the Philadelphia Department of Public Health. We are a division within that umbrella, even though we are co-located in a building with the Philadelphia Police Department. Next slide, please. So in 1951, the city charter was changed, and it eliminated the office of the coroner, which was an elected official, and replaced the department with, at that time, the position of examiner. I'm not quite sure when the name changed from examiner to medical examiner, but that did occur over the years. And the first person to hold the position of examiner was Dr. Joseph Spellman. Next slide. So in a sense, when we look at the regulations here in Philadelphia, again, the coroner was abolished, and so no one could be elected to that position. And then basically all the powers and duties that previously had been held by the coroner were then transferred to, again, the examiner, or as I said, we have evolved into medical examiner. Next slide, please. So again, the MEO, we have been following Title 16 of the Pennsylvania statute, and this Title Chapter 4 applies to all the counties, including Philadelphia. And basically, it says that it is the duty of the coroner and deputy coroner to investigate cases of sudden or violent or suspicious deaths, and to make an inquiry into those deaths, and if necessary, perform an autopsy to have additional facts revealed in the case. Next slide, please. So we've actually been following this Chapter 1, which technically applies to Class 3 through 8 counties, but both Philadelphia and Allegheny County do follow these provisions. And so in this chapter, it lays out the types of deaths that we are supposed to investigate. So you can see that, we go from Category 1, where these are sudden deaths that don't seem to be caused by readily recognizable disease processes, or the physician doesn't feel that the death can be attributed to a known disease process. We then progress on to deaths that are under suspicious circumstances, where alcohol or drugs may be involved. Next slide, please. And then the categories of death that people typically think of when they think of a coroner or medical examiner, those deaths that are occurring as an obvious result of violence or trauma. And that can be anything from a true accident to self-inflicted to a homicide inflicted by another. But also in this regulation, or in this chapter, if we look at number 9, they speak to deaths of persons whose bodies are to be cremated, buried, or otherwise disposed of as to be therefore unavailable for examination. So the intent of this provision is that before a body is unavailable for any sort of examination, that the coroner or medical examiner at minimum reviews the death certificate to see that it is appropriate, and that no further inquiry or investigation needs to be done before the body is cremated or buried at sea, and then truly it will be forever unavailable for examination or obtaining fluids or tissues for any other additional testing. Next slide, please. So again, when we would be looking at the cremation certificates to approve or not approve the cremation, we are also looking at it with whether we need to accept jurisdiction of the case. So even though we would just be initially reviewing the death certificate and the cause of death that is listed on the death certificate, the medical legal death investigators and the medical examiners will have to be mindful of the issues regarding jurisdiction. Does this case meet one of our criteria to actually become a medical examiner's case? We also have the issues with what we call the unwilling physician, someone who has been taking care of a person for a long time, but then will say, well, I wasn't there when they died, or I don't know why they died, and will not sign the death certificate. So if we determined from review of the death certificate and then if we need to obtain additional records that this decedent actually falls under medical examiner purview, then we have the option of just doing a medical record review and then issuing a new death certificate, bringing the body to the office and just performing an external examination of the body. Or if we're suspicious of something like a homicide, then we would need to proceed with an autopsy. Next slide, please. Again, just some questions that might come up from families possibly. Again, with a forensic autopsy, unlike with a hospital autopsy, consent is not required from the legal next of kin. This is our mandated duty to perform an examination, which may include an autopsy. With many of our deceased, the identification is not known at the time. We may not have medical records, but again, it is our mandate to determine cause and manner of death. Next slide, please. So again, things that people typically think of as coming under medical examiner purview are the violent or suspicious deaths. But we also do need to, at times, take charge of the sudden and unexpected deaths, more typically in our younger individuals. We do take custody of unattended deaths, meaning we may have an elderly individual who, just by looking at him, we know has a multitude of medical conditions, but they haven't seen a physician in many years. And then we also will take custody of any deaths in custody, even if they have been in the hospital for days to weeks. Next slide, please. So again, we will determine cause of death, which again is that disease or injury that initiated this lethal chain of events that brought about a person's death. This is actually very important in the case of cremation certificate review. We will have persons who have been in, let's say, rehabilitation facilities or nursing homes for a very long time. So long, in fact, that why they initially ended up in such a facility is unclear. But this is where, if I have a 40-year-old and their cause of death is something vague like pneumonia, and they're coming from a nursing home, our investigators will be taught that those deaths need to be investigated, because that person could be in that state, let's say because they have uncontrolled diabetes with accelerated arteriosclerotic cardiovascular disease, and that's why they develop pneumonia. Conversely, it could be someone who was shot with injury to the spinal cord 10 years prior and has lived as a quadriplegic for those years, and that's why they got pneumonia. So in that case, this is a delayed homicide, even though it is 10 years, and it needs to, that body needs to be seen and examined by the medical examiner's office. Next slide, please. Again, many of the death certificates will have mechanisms of death listed, which again are non-specific pathways to death. And again, in my example of pneumonia, we can get to pneumonia through many different initiating causes of death. Next slide, please. So again, when we're looking at the death certificate, we want to see that the cause of death is etiologically specific, that it can stand alone on the death certificate versus just being a mechanism of death, which will have this very broad differential and does need to be investigated. Next slide, please. So with that, for our office to determine the cause and manner of death, we look at these different pieces of the puzzle to determine why the person's cause and manner of death. So we do look at the circumstances, if there's any physical evidence, and if we may need to do a postmortem examination or sort of a deeper dive into medical records to uncover what initiated this chain of events. Next slide, please. Okay, Ben, I'll turn it over to you.
Thank you, Dr. D'Angelo. Okay, can everybody see my screen?
Yes.
Great. So this is the proposed regulation requiring a permit for cremation, burial at sea, body donation, or other non-burial disposition methods related to deceased persons. In the whereas clauses here, we lay out the Philadelphia Code section that Dr. D'Angelo was explaining that gives her the power to examine bodies and determine cause of death and perform autopsies. We also reference the state law that the medical examiner's office has been operating under to investigate all suspicious, violent, and sudden deaths. We note here that the Commonwealth, that other counties in the Commonwealth have been using this permitting process, and Philadelphia is now proposing to use a very similar process to those counties under state law. And we note here that the county code establishes a standard fee of $50 for this permitting process, and that we will be following that as well. So moving down into the definition section for this permitting process, we define a deceased person as a person whose death occurred in Philadelphia. The chief medical examiner is the Philadelphia chief medical examiner, who is appointed by the commissioner of the Department of Health. The medical examiner's office is defined because there might be other medical examiners involved besides the chief medical examiner in these processes. And the definition of non-burial disposition, it comes from that state law that Dr. D'Angelo was referencing, and it's a disposal of a deceased person by cremation, burial at sea, body donation, or any other manner which renders such body or remains unavailable for examination. And the permit itself, it will be called a non-burial disposition permit, and that is a permit that's issued by the chief medical examiner's office for the non-burial disposition of a deceased person. And the person in charge of non-burial disposition is the person who will be applying for that permit through the medical examiner's office. So the way that this permitting process operates is that in order for a person in charge of non-burial disposition to, perform a cremation or burial at sea, they need to apply to the chief medical examiner's office for a permit, and they will submit an application that is currently being developed by the department. And once that application is submitted, the chief medical examiner will review the application and the death certificate together, determine whether the death was violent, sudden in nature, or otherwise suspicious, and whether it requires further investigation, whether that be the collection of additional documentation, medical records, or if needed, an autopsy would also be performed. This permit is set up so it shall be issued by the medical examiner's office unless they determine that there was the death was caused by something other than natural causes, and further investigation will be needed. So the applicable fees, like I mentioned, are also $50, and this regulation will take effect on January 1st, 2024, and that's to give the department time to do some outreach to the affected regulated parties, and also to develop the systems for accepting applications and the payment process as well. So now I'll turn it back over to Dr. D'Angelo to finish your presentation.
So I'm sure one of the questions is what will be some of the expected outcomes from this regulation. One is that it will just bring Philadelphia in line with the practice in the surrounding counties and frankly the rest of the state. Adoption of this measure will not be a new procedure for the vast majority of the funeral homes and crematoriums and the transport services that operate in this area. Next, please. From my time in other jurisdictions in Virginia and The District of Columbia review of such cremation permits actually resulted in an additional 1 to 5% of those cremation permit reviews actually falling under medical examiner jurisdiction. In 2022, the Board of Vital Statistics asked our office to review a little over 100 cases because of certain words that were in the cause of death statement. And of those cases, about 40 of them were accepted as medical examiner cases. Just for an example, if there are about 9,000 cremation that are performed for Philadelphia in a year, probably about almost 50% of those cases may have already been dealt with by the medical examiner's office. So that would leave us with about another 4,500 or so that would be new cremation reviews. So again, if we think of this 1 to 5% of those cases that would then become medical examiner jurisdiction, that would add 45 to about 200 additional medical examiner cases. But initially our investigators will be dealing with 4,500 cremation reviews. Next, please. So with the fee that comes with the application, we would use the generated revenue to help cover the costs associated with the additional investigators and medical examiners who will review these cases. The revenue could also help cover costs associated with continuing education of the staff and other items that are related to death investigation and transport of decedents. This revenue would also help provide funds to help identify unknown decedents through both the standard and enhanced DNA technology and genealogy. And then finally, the revenue will help provide a dedicated funding source so that we can bury our unknown decedents and also bury the cremains of unclaimed individuals. Next slide. Oh, that's it. Thank you. Thank you for your attention.
Great. Thank you, Dr. D'Angelo. So now I'm going to turn things over to the board for any questions, comments, discussion points.
I have a question.
Yes.
Can hear me okay? Just in terms of the fee, so that, I had two questions. One you answered, because if there are fees, Tyra, I'm sorry, Dr. I didn't see you.
Go ahead.
You see the hand up with the lighting in the background. I apologize.
Yeah.
The fees generate revenue to help you, because I was going to ask that the impact on the cases and the staff to do the cases. But now I have the flip side of the question, which is, what is the fee? I'm thinking about more typical scenarios of the choice of cremation and families impacted by having an increase in the fees that they're paying, right? Because this fee is going to be passed on to individuals who are planning a cremation or choosing that for their loved one, or the loved one's chosen it, this is already an incredibly expensive process. And so I just want to understand the fee we're passing on to folks.
So again, it's the sort of state mandated fee of $50. It's actually one of the lower fees in this sort of mid-Atlantic area. The District of Columbia charges $125. Virginia is now at $100. So I think the fee is actually quite reasonable.
Thank you.
Dr. Brian Stevens.
Yeah, I just had a basic question. So currently there is no regulation requiring a permit for this that exists in Philadelphia. Is that true?
Correct.
Wow. Okay.
I should probably add that one of the things that Dr. D'Angelo and I sort of jointly discovered, and discovered is the wrong word, but are trying to come up with solutions to, is the fact that for people who die in Philadelphia and there's no one who claims their remains or no one who can pay for a funeral, that the medical examiner's office does do cremations, but there hasn't been a funding stream to support doing the next step. And so we have begun doing these. This year we did the second annual funeral for people who die homeless in memory of Mike Hinson. And the health department did support that just with general fund, along with other departments, kind of on the principle that it's the right thing to do. We need to be putting people to rest and not keeping them in the medical examiner's office, but coming up with a sustainable plan for that so that it's not like someone decides to do it, but it's something we have a system for, is part of what we're trying to build in here.
And to add to that, that is a tremendous help, but, unfortunately we are having to cremate at least 350 unclaimed bodies every year. And as you can imagine, that number is going up. And I, as Dr. Medical said, it would be great to have a funding source where we can, put these cremains to rest and not have to have them stored right in our office.
Are there other questions or comments?
I would like to move to approve the amendment as presented.
So before we do that, were there any public comments, Ben?
I have not received any public comments.
Okay. And I think we only have two members of the public here, but if either of you wanted to make a comment, I just want to make sure that you have a chance to do that. We're having people put those in the chat, if so. Okay. Not seeing anything. Is there a move to approve the regulation as written?
So moved.
Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed?
Aye.
Great. Thank you all. And thank you, Dr. D'Angelo. And although you're welcome to stay on, you also could go back to your evening if you'd like. So thank you. I'm now going to turn things over to Ben to go over the amendment to the regulations governing the control of communicable and non-communicable diseases, conditions regarding mpox and pediatric multi-system inflammatory syndrome.
Thanks, Dr. Medicolegal. I will share my screen here. Is everyone able to see? Okay.
Yes.
Thank you very much. So these two amendments to the regulations governing the control of communicable and non-communicable diseases really relate to, first, a name change for monkeypox to mpox, and for pediatric multi-system inflammatory syndrome, it's the addition of multi-system inflammatory syndrome in adults, and also changing the name to multi-system inflammatory syndrome in children to conform with the CDC's updates to both of those diseases. So the board passed in May 14th, 2022, in addition to the reporting regulations that introduced pediatric multi-system inflammatory syndrome as a reportable disease. And we've decided, the Division of Disease Control has decided to include both Miss A and Miss C, like I said, the adult and children version of these syndromes under one umbrella. And you'll see that in the text below. And in August 4th, 2022, the board approved the addition of monkeypox as a reportable disease to the reporting regulations. But recently, in November of last year, the World Health Organization announced that it will be using the term Mpox instead of monkeypox, and the Biden administration also released a statement in support of that decision. And they noted as a step to reduce the stigma associated with that disease that's gone along with the recent epidemic of monkeypox. So moving on to the proposed changes to the reporting regulations. First, Section 2 of the regulations is just where the board is declaring the name of the disease or condition that's reportable. And the change here you'll see to pediatric multi-system inflammatory syndrome is to change it to just multi-system inflammatory syndrome, which includes MIS-A and MIS-C. And you also see that monkeypox has now been changed to Mpox. Since we're updating these diseases names, disease control also looked at the specific reporting criteria for these diseases, which appear in Section 10 of the reporting regulations. So we also had to change the names there. And for multi-system inflammatory syndrome, we're actually removing the requirement that it be reported within 24 hours, because that's not the standard that the CDC uses. And it's going to be reported in a manner specified by the department. And it's my understanding, and Dana Pro is on the line, so if I mess this up, you can correct me, Dana, but the Division of Disease Control is working on an announcement about those specified reporting mechanisms, but it'll essentially be a fax of the MIS-C reporting form, which is already being used by pediatric hospitals, or hospitals can fax over medical records that show that the criteria established by the CDC has been met for MIS-C. And so we've also deleted this specific reporting criteria because it was really for pediatric multi-system inflammatory syndrome, and we've just referred to the CDC's criteria because it may evolve in the past, and this is a way to incorporate any evolution in the regulations. So moving down to Mpox, we've also changed the name here in this section, and we've also removed specific reference to isolation precautions that spelled out what to do with the evolution of lesions. That was determined to be unnecessary because this section of the regulation also refers to the following the isolation guidance that the CDC has issued, and as it may be updated, so it really conforms this reporting requirement with the reporting requirement change we made for MIS-C above. And there were no other changes to the reporting requirements other than conforming the change from monkeypox to Mpox here.
Thank you, Ben. So are there any questions or discussion points for the board? All right. And any public comments, Ben?
Let me double check. I am not seeing any public comments.
In that case, is there a move to approve the regulation?
So move.
Is there a second?
Second.
All in favor?
Aye.
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 Any opposed? Okay. Well, thank you very much. I also just want to note, since we are here together, as this came across my screen, it looks like City Council has given preliminary approval to the mayor's fiscal 24 budget. It will be difficult to see this from the numbers, but this is a substantial investment in health. The reason it will be difficult to see this from the numbers is that we closed the Philadelphia nursing home. So our overall number goes up, but the number actually being invested in public health in Philadelphia, I mean, our overall number goes down, but the amount invested in public health goes up significantly. And that includes separate funding in the capital budget to build 2 new city health centers, which we
Congratulations.
desperately needed to do. Yeah. So anyway, so it feels like we should just take a moment to make sure that you all know that that's happening.
Fantastic.
Yeah, exciting times. So, I mean, you know, nothing's done till it's done. We want to see shovels in dirt. We want to see buildings go up. It will take some time to get there, but
step in the right direction.
Yeah, exactly.
Congrats.
Thank you.
So thank you all so very much for your time and your insights. And I'm going to adjourn this meeting at 7:14 p.m. Everybody stay safe.
Thank you.
Thank you. Take
Thanks. Have a good evening.
Yeah.